Hi guys, as you all know, at present, whole world is fighting against COVID-19 and there are many articles, case reports and protocols about the management of this illness. But unfortunately, no specific treatment so far has been shown to decrease the mortality outcome in patients with COVID-19 apart from dexamethasone. In this video, we will talk about the use of corticosteroids, mainly dexamethasone, in this COVID-19 pandemic. We have given the references in the description of this video. You can refer them if you have any doubts about this. Many clinicians have different opinions and different experiences. In this video, we have summarized what majority of articles or protocols suggest. This video is totally educational. We do not advise any kind of treatment. Kindly seek consultation from your doctor in case of any symptoms. So welcome again to Intellect Medicos, where learning is made easy. I am Dr. Chirag Madan, working as an intensivist ICU consultant at Apollo Hospital, New Delhi. Multiple agents such as remdesivir, oseltamivir, hydroxychloroquine and azithromycin have been tried but without any definitive outcome benefit. Studies with immunomodulatory agents like tocilizumab and other IL-6 blockers for countering the cytokine storm has not been able to show any significant outcome benefit. Although in some clinical trials and case studies, it has shown some benefit in few patients. Corticosteroids have thought to be useful during cytokine storm, as this usually happens in the first 5 to 7 days. Ideally, steroid therapy should be tried in this period, particularly at the onset of dyspnea or even earlier, to prevent the progression of cytokine storm. The anti-inflammatory properties of corticosteroids reduce systemic inflammation and exudative fluid in the lung tissue and also prevents further diffuse alveolar damage, thereby improving the hypoxia and minimizing the risk of respiratory failure. In most of the studies, independent risk factors associated with the risk of progression of ARDS to death includes older age, organ dysfunction, and coagulopathy, as manifested by higher levels of lactate dehydrogenase, that is LDH, and D-dimer. Most of the studies on use of corticosteroids in COVID-19 have shown variable results, that is principally because of marked heterogeneity in the methodology of studies. The principal steroid used in most of these studies and other ongoing trials have been methylprednisolone and dexamethasone because of their high bioavailability in the lungs. Methylprednisolone has the least mineralocorticoid activity, while dexamethasone possesses highest glucocorticoid activity. Theoretically, methylprednisolone has the advantage of parenteral administration, a quicker onset of action, and a short duration of action compared to dexamethasone. This makes the risk of long-term side effects like fluid retention, hypokalemia, hypercortisolism, dysglycemia less likely with methylprednisolone. None of the studies shows which steroid is better. However, the most robust data among steroids came with dexamethasone in the recovery trial, that is randomized evaluation of COVID-19 therapy, which showed the most significant mortality benefit with low-dose dexamethasone. This trial showed an impressive 35% mortality reduction among the sickest patients on invasive mechanical ventilation and 20% reduction of mortality amongst patients on oxygen therapy with or without non-invasive ventilation. In addition, patients on dexamethasone had a statistically significant reduction of hospital stay and an earlier likelihood of discharge. It should be noted that majority of studies with corticosteroid intervention were done in the patients with serious or critically unwell patients, particularly those who required high flow nasal oxygen or ventilation. Studies on the patients with mild COVID-19 did not show any significant benefit. These are COVID-19 treatment guidelines by NIH, We have given the link of these guidelines in the description box below. Recommendation for patients with COVID-19. On the basis of recovery trial, COVID-19 treatment guidelines panel recommends using Dexamethasone 6 mg per day for up to 10 days for the treatment of COVID-19 in patients who are mechanically ventilated and in patients who require supplemental oxygen but who are not mechanically ventilated. The panel recommends against that it should not use dexamethasone for the treatment of COVID-19 in patients who do not require supplemental oxygen. If dexamethasone is not available, panel recommends using alternative glucocorticoid such as prednisone, methylprednisolone or hydrocortisone. Now coming on to the monitoring and adverse effects of corticosteroids. It is essential to monitor side effects like hyperglycemia, secondary infection, psychiatric effects, avascular necrosis and many more. Prolonged use of systemic corticosteroids may increase the risk of reactivation of latent infection. Example, hepatitis B, herpes virus, tuberculosis, etc. Dexamethasone is a moderate cytochrome P450-3A4 inducer. As such, it may reduce the concentration and potential efficacy of concomitant medication that are CYP3A4 substrates. So drug interactions should be kept in mind as well. Use of other corticosteroids. Whether use of other steroids, example prednisone, methylprednisolone, hydrocortisone, for the treatment of COVID-19 provide the same benefit as dexamethasone is unclear. The total daily dose equivalents to dexamethasone 6 mg for these drugs are prednisone 40 mg, methylprednisolone 32 mg and hydrocortisone 160 mg. Half-life, duration of action and frequency of administration vary among corticosteroids. It is divided into long-acting, intermediate-acting and short-acting. Dexamethasone is a long-acting corticosteroid having a half-life of 36 to 72 hours and it has to be administered once daily. Whereas prednisone and methylprednisolone, they are intermediate-acting corticosteroid having half-life of 12 to 36 hours. Hydrocortisone is a short-acting corticosteroid having a half-life of 8 to 12 hours. Hydrocortisone is commonly used to manage septic shock in patients with COVID-19. Managing a COVID patient is actually a difficult task because there are varied presentation. Many clinicians are using different dosages of steroid taking into account all the factors, the co-morbidities, clinical condition, parameters and the investigations. Do share your experiences in the comment section below. We would love to have your feedback. Thank you guys for watching this video. Stay healthy and safe. Take care. Bye-bye.